I slip on some algae, both legs come up, and I come right down, straight on my left PSIS, kind of low back area.
Okay.
And since then, it's kind of, got real bad. We addressed it with some castor oil and like some soft tissue at the time, but it's kind of like lingered ever since.
Okay, so tell me which back pain.
Alright, so
When did it start?
yeah, it's been going on for off and on, about 4 years.
Okay. Did anything happen before that initiated it? Any injuries, car accidents,
You know what there was?
kung fu fights,
there was an injury.
Mexican street brawls?
No, not fortunately, staying out of trouble. But actually a big slip up at Slide Rock.
Okay.
I was
The irony.
I know, slide. Yeah, literally slid out, chasing what was it? Have you heard of it was a cross between an apricot and a plum quat.
You were chasing a fruit?
It was rolling away. And
You can't make this up.
I can't. I'm going to chase
so
after.
glad this is on film.
I paid a premium too. It was like $2 a plum quad or whatever it's called. Yeah, it's dinosaur egg. It was really delicious. It starts rolling away. I start to chase it. I slip on some algae. Both legs come up, and I come right down, straight on my left PSIS, kind of low back area.
Okay.
And since then, it's kind of, got real bad. We addressed it with some castor oil and like some soft tissue at the time, but it's kind of like lingered ever since.
Okay. What's it feel like?
Feels like an ache, like just a general.
Okay. And where?
I'd say it's located on the left side of the low back, close to the sacrum.
Okay. Any radiating pain?
No radiating pain. Maybe an associated. Sometimes I'll get hip pain, like today actually.
Okay.
I've been having
Kind of wraps a little bit.
I may wrap.
So when you see this, you can, it's classically called a C sign, which is usually attributed to a labral tear. But because of the way that SI radiates, I also consider SI in that when patients go, yeah, it kind of wraps like this, right? They're making that C sign. Okay. What makes it better?
Let's see. Hot showers.
Okay.
In a hot shower, that helps it out. I was doing some.
So that tells me muscle relaxation helps. Okay.
It was more for the radiating pain or the posterior hip pain, but I was doing some piriformis kind of stretching, kind of pulling this up like that.
Okay.
Holding that. I noticed after doing that for a little bit, went down a bit.
Okay. Anything else?
I don't think I've done too much else. Oh, some frequency. I do sometimes some microcurrent.
Okay.
That helps with it.
Have you ever taken any NSAIDs, any pain relievers, any muscle relaxers?
No pharmaceuticals, but I'll do like proteolytic enzymes.
Okay.
I noticed that helps.
Okay.
So I did turmeric for a while. It was getting better.
Okay. So I always ask point blank if because a lot of patients they'll have tried an opioid and they'll have tried it for a week and it didn't help. So when you're asking what helps, what makes it worse, it's you're not actually asking what have you tried that didn't work. So I always point blank ask about NSAIDs, opiates, muscle relaxers, and then depending on the type of pain, if it seems more nerve related, I'll also ask about like gabapentin or pregabalin or basically our other neuropathic agents, because all of those help tell you stuff about what's going on. What makes it worse?
So you know what? Certain movements, but it's none that stand out in particular. But maybe if squat. Oh yeah. Like if I'm squatting, if I don't watch my form really carefully, it'll aggravate it.
And what aspect of your form? Like, is it knees fall in? Is it low back rounds? Like what?
Yeah. It's a low back. If I don't guard the low back, I'm
so
not.
if you don't maintain an arch.
Yeah. If I'm not engaging the core, if I get sloppy and engaging the core, maintaining the arch,
Okay.
it'll aggravate it.
So already right now, facets like just kind of dropped a little bit on my list. I'm still gonna evaluate for it, but because if he loses the arch in his low back, what happens to the facet joints? They actually open up.
Yeah.
Because extension closes the facet joints, and so if he goes from here and when this happens, his pain gets worse, it's likely telling me, now again, it could be the capsule of the facet joint, so I'm still keeping facets in the picture, but facets kind of drops with that because of that. Okay, anything else you can think of that you think is important that I don't know?
You know, I have the only other pertinent maybe medical history. It's like mild scoliosis
Okay.
could be going on, but other than that, it's nothing else.
Okay, any numbness, tingling, weakness, loss of bowel function, loss of bladder function?
No.
Okay.
No. A week ago, I had my second toe. My second toe, I noticed actually had some tingling.
Okay.
Lasted for about 10 minutes. It was pretty interesting.
Okay,
That's it.
that never happened before, just the one time.
No, just that one time. Never happened again.
So likely just an incidental thing because this has been going on for 4 years and this happened once in 4 years. So that's an HPI, okay? You could that was what, 6 minutes? So you can really condense into the really important stuff on knowing it's your basic OPQRST, just keeping it really condensed. And that will come over time as you guys start to learn that I could sit here and talk for 20 minutes more about his pain, but I already know enough about it before going into my exam. So differentials at this point, probably top 2 are going to be sacroiliitis and then a middle or superior cluneal nerve neuropathy. Would be a mononeuropathy if it's just one of them involved. And then facets are still at play. And those are those are the big 3. So let's do some, I always start with range of motion, so flex forward at the hips. No, stay seated, yeah. Any pain?
No.
Okay, go into extension, so chest all the way up to the ceiling. Any pain?
No, not there.
Okay,
Did that.
let's turn and look over left side. Any pain?
No.
Okay, turn and look over right side.
A little bit.
Where? On the left?
Yeah, right in there. Not so much. Where I feel the pain is a little higher.
So this is always a good thing to clarify. Is that the pain that you're seeing me for today?
No.
Okay, so we may have something going on with facet joints because remember, when we turn this way, what happens to the contralateral facet joints?
Compress.
They close down, they compress, and so we may have a facet thing going up higher, but either the pain from this, because of pain gate theory, the pain from this is basically that's what his brain is focusing on, and so you don't feel the other pain, or it's just not significant enough for it to actually affect his day-to-day. Excuse me, because he's rarely ever in this extreme position, right? Okay, let's lay on his back. All right, nice and relaxed, Any pain?
Yeah, it's a little bit more, I would say I'm feeling that posterior hip pain when you do that.
And is that posterior hip pain, how does that fit into what you're seeing me for today?
I felt that pain in the back for just a moment though. During when you were bringing it up,
Okay.
it was elicited, but it didn't stay. Just for a moment.
The low back, you're
The
saying?
low back, yeah.
Stay relaxed. Let me know if it happens again. Nothing? Okay. I'm gonna bend the knee here. So we had straight leg raise, now we're gonna go into Faber. Take a deep breath and relax. Always have them breathe and relax because there's so much guarding on the adductors. Any pain here?
No.
And then apply load. Any pain here?
A little bit.
And is that the pain we're talking about today?
Yeah.
Okay. So patients like Alan are who, it's that, what is that in TCM, the more lanky types? Do you remember
Wood.
the wood type?
What type?
Your more wood type patients or your lankier patients, they're generally going to have more joint play. They're generally more flexible. And so if I hadn't of, because this is, you'd think if he's got SI and this is going to be positive, like look at this range of motion. But if this is not stressing his end range of motion, then we're not going to get a good test.
Mm-hmm.
That's why applying the pressure is important in that situation. I'm going to check flexion, anything here,
No.
okay? And then come into,
And the anterior hip, but not the posterior hip.
Okay.
Yeah.
and then fader, anything here,
No, not on the back.
okay. And we'll just run through this side, nice and relaxed. Any pain? Okay, we're gonna bend the knee, relax. Any pain? Any pain? Okay. Anything here? Anything? Okay. So then we can check a, let's say you scoot towards me a little bit. These are one. Oh, sorry, that way. Yeah. This is, come off. Anything here? This is a modified chems test, but you'll also get some SI involvement with it. This is really great for your elderly patients where they have very little range of motion, because this is the least sensitive test for any extension in the low back, because this will cause some mild extension in the low back, but not a lot. So I would never, even if he had facet stuff, I would never expect this to be positive on him. It's more so like your 60, 70, 80-year-old patients. And we can come and check Gainsland's here. Any pain here? Okay, I'm gonna apply pressure. Any pain?
No.
Okay.
That's left-sided, Gainsland's?
Technically, yes, left-sided. Even though, remember, because you're getting a rotation and a counter-rotation on both tests, it'll be, you can get a positive on both sides.
But for charting purposes.
Yeah, for charting purposes. This off. Anything there? Anything here?
A little bit
On the left side?
on the left side, yep, in the back and the front.
Okay, and is this different than what I just did, flexion at the hip? Because you didn't have that on the back, correct?
No.
Okay.
It's it's tough because I think the anterior pain's a little louder.
Okay.
So it was a little different. That did cause just a little bit in the back.
Okay. So even though that's not a true positive for Gainsland's test, we know that we're getting a rotation in the SI joint on his left side with that, and so that still factors in for me. All right, let's go to our dial thrust. So remember, your hand, the thenar and hypothenar eminence are going to go on the sacrum. Your middle finger should be running up the SPs. Come up here and inferior drive. Any pain?
Yeah, a bit in
Okay.
the back.
And that's the same area that we're talking about?
Yeah.
You always want to be confirming that it's the area that the patient's seeing you for. Anything on this side? Okay. And then we have our, I'll do it from the side, SI joint distraction and compression. So remember, the action that you do is the name of the test. So distraction is going to be, so ASIS, ASIS, any pain? Okay, and then have you lay on your side. Bend the knees. Good. Remember with this, make sure they're stacked. You don't want them rolled back here, you want them stacked. You're going to find iliac crest, and I drive towards the belly button. Because if you drive towards the belly button, this is your axis, and that axis is going through the SI joint, right? So here. Any pain?
No.
Okay. And then flip to the side.
How often do you see SI compression or distraction being positive?
Compression or distraction, rare. I think I've had like 2 positives in the past year and a half that I've incorporated these tests. Or you can sit up actually. And compression, maybe 10% of the time that there's SI involvement. So, yeah, pretty low compared to your Gainsland's favor and thigh thrust. So usually those are the 3. And then palpation. So SPs, anything along the SPs?
Down there.
And is this familiar?
It is. It's just it's there. That's closer to where the
So
finger feels.
what happened there? You want to turn so they can see. Yeah. Yeah. Can I pull this up?
Yeah, absolutely.
So first palpation was here. When we were down here, he started to notice that he was feeling a little bit. When I did this, which was slightly going lateral, now I'm on the sacrum and he feels it. Remember, your ligaments for your SI joint attach sacrum to ilium. So if you're palpating the sacrum and that's recreating some of their pain, then you know the posterior sacroiliac ligaments are involved. And then here's our PSIS, so any tenderness. And this is this the area that you feel pain?
Yeah, and more so right in there.
Okay. So that's SI. So, sacroiliitis on the left side.
Left side. Come on, left side.
But you see how we kind of worked through using the history first to kind of orient what we're looking for, and then the physical exam for, okay, how can we hone in what we learned in the history to be really specific. So a case like this, I wouldn't feel the need to do like DTRs or wet cold sensation for dermatomes, because I don't think there's a dermatomal component, and that might just lead us astray. So.